Hi, it's Chelsea with Wound Care University and Wound Centrics, and we're going to be doing your annual safety review right now, just going over the fundamentals of your safety program and how you can best make sure that you are running a safe hyperbaric facility. This is an example here of the signage that you have throughout your center. There's probably one in your hyperbaric room right next to the chambers. Likely there's one in your dressing room, and there might even be an additional one in your waiting room as well. That's kind of best practice is just to have these in as many places as possible so that your patients and staff are always being reminded. They're very familiar with the safety restrictions. Just to make it very simple, when you're doing an initial consult with these patients, you're speaking to your patients or your staff even, the simple reminder is if we didn't give it to you or you weren't born with it, it's probably not going to go in the chamber with you. So no shoes, hair gels, jewelry, perfume, watches, batteries, hairspray, cigarettes, medications, including medication patches, newspapers, metallic objects, coins or money, any kind of phone, a Kindle, iPad, especially heat warmers. So anything that generates heat is not going to be allowed inside the chamber. Hearing aids, anything alcohol or oil based is simply not going to go inside the chamber. Any kind of nail polish, especially during that first 24 to 48-hour period, we don't want that inside the chamber. That would also apply to hair dyes, stockings, matches, of course, makeup, lighters, pagers, keys. We're also very specific about the type of fabrics that we allow inside the chamber. So we would like to see 100% cotton. If for some reason that's not realistic for your facility, that's fine. You can do a polyester cotton blend that is NFPA approved. However, the maximum amount of polyester you can have is 50%, and it seems like the standard hospital linen that we get is higher than that. So you do have to be very mindful and careful when you are getting linen from your facility or from your central supply that it meets the hyperbaric criteria. We want to make sure that when it is winter time or if you have folks that are on dialysis, we are constantly screening and asking them if they have hand warmers on them. Those are not even allowed in the hyperbaric center because of the fire and explosive hazard that they pose to us. There has been 4 incidents of fire chambers and explosions that have been a result of these hand warmers or body warmers going inside the chamber. So we have to be very diligent with making sure that those do not get inside our HBO room. Another safety point to be concerned about is titanium. If your patient were to drop their glasses or have a seizure, any titanium framed glasses, if that were to fall on the inside of the chamber at pressure at 100% oxygen and strike and break in any way, that exposed titanium can cause a spark. And we know what happens when there is a spark in the hyperbaric chamber. So we have to be very diligent to make sure that there is no titanium going inside the chamber. So they are usually marked with a TI. That's how you know it's titanium, but you can also tell if it's very like bendy and flexible and lightweight. It's likely titanium. I also don't really want any metal framed glasses going inside the chamber. If your patient were to drop them, have a seizure, and even a normal metal that's allowed, quote unquote, inside the chamber, if that were to hit the inside of the chamber and cause a big scratch, that cannot be buffed out. It is about $80,000 to replace the acrylic, so I'd rather we just not introduce anything in there that could damage our acrylic. Dentures do need to be removed prior to therapy. Full dentures, partial dentures, doesn't matter. Those cannot go inside the chamber. If your patient were to once again have a seizure, especially with the more ill-fitting dentures that could fall into the back of the airway and pose an obstruction. And since we are monoplace based, it does take a while to get your patients outside of the chamber, so we would like to not be in that situation. And truly anything that your safety director or you feel is unsafe to go inside the chamber should not go inside the chamber. So always use your best judgment, do a lot of research, especially if someone comes in with something that's new. There are new wound care products constantly on the market. There's new medications that are being introduced all the time. So doing a little, research and trying to figure out, hey, is this new medication? Is this new product? Is this new supplement? Would this be any kind of risk for the patient in the chamber? Is always a really good way to think and be safety conscious. In all of the incidents that we review in our hyperbaric medicine course, you have been through, you have probably noticed that most of these incidents have been due to human error. It's people putting things inside the chamber they're not supposed to. It's not screening patients appropriately before they go in. A lot of it ties back to complacency. So we need to make sure that we are preventing anything from happening, because once something is inside the chamber or the chamber is unsafe, that's a whole situation. So we as a group need to be very diligent and make sure that we have a good maintenance program in place. So we have the yearly maintenance where someone comes out and does, the big yearly maintenance, but there's also daily items, weekly items, and monthly items that your Hyperbaric staff is doing. And as a provider, I really encourage that all of our provider staff trust but verify. In all of these instances where we see that there was a catastrophic chamber fire, it's not just the techs or nurses that are held liable, it's also the physicians, medical director. All of those folks are very much implicated in these incidents as well. So even if you have a safety director that you trust very much and you think your safety program is good, it doesn't hurt to just ask to make sure that they know that there's an extra layer of accountability there, that you know what to look for, that you're asking those kinds of questions, and just hold everyone to a really high standard of accountability to make sure that your safety program is as good as it should be. That is a big part of what I do too, is making sure that our logs are done every day. But I cannot be in every clinic, and you can definitely have a big part in the safety program, your clinic, and making sure that everything is being done there how you want it to be, and all the documentation that has your name on it ultimately reflects how you would like it to be run. When it comes to your policies and procedures, we have access to those, you know what they are, but it doesn't benefit anyone necessarily if it's in a binder somewhere on a website, which is why once a month we go through and we review that with our staff. In the safety program, we have a safety topic that gets reviewed every month and a policy and procedure that's reviewed every month as well, just to keep it fresh in everyone's head. We do safety drills quarterly, and our providers are always involved in those safety drills as well, because you guys have a big role to play in case there is any kind of an emergency. You guys are the ones that are determining how quickly we're bringing our patients out of the chamber, doing the assessments on these patients when they get out. So you are a big part of those safety drills as well. Always review your emergency protocols, especially with new staff. It's an opportunity kind of for everyone to get a refresher, and just be a part of that ongoing safety education and training program that we have in place. Another big part of this too is that pre-hyperbaric patient safety checklist. If people are actually following the pre-dive checklist to a T, you're not going to miss anything. It goes over all of the medications they could have taken that could be posing an issue. Did you take a diabetic medication? If so, what kind, what dosage? Did you eat? Do you have any of these prohibited items on you? So where we run into trouble is when folks start getting complacent and comfortable and they think, oh, this is our patient's 40th dive. Nothing could happen because they're super used to this now. The problem is your patient is probably also getting complacent around the same time potentially, which can lead to some real big issues with them feeling a little too safe and thinking that they can bring things in that they're not supposed to, or just simply forgetting that they're supposed to remove certain items. So whether it's their first dive or their 50th dive, we need to be asking the same questions every time before we close the door on that chamber. So we know that the biggest risk associated with hyperbarics is fire. So we need to know what our threats are. And of course, prevention is key. So the biggest thing that you can do is make sure that nothing is going to get inside your chamber to start a fire to even start with. That being said, if there is an incident, you should know what your suppression capabilities are, who is responsible for each part of your code red plan, having good maintenance in place, knowing that you do your drills frequently and everyone knows their roles, and just having a healthy respect of the fact that oxygen, although it's not flammable all on its own, does add the explosive factor to any kind of a fire. So we just need to be very diligent to make sure that there's nothing that we could be doing in our practice that could cause a fire or any kind of fire risk in the chamber or in the chamber room. So there's a lot of things that we can do to make sure that we are preventing fires. The kind of linen, so 100% cotton or that polyester cotton blend that we've discussed, no pockets, no clothing from home. Your patients might say, oh, well, this is 100% cotton and I bought it at Walmart and it's safe and it's fine. If we did not give it to them once again, it will not be going inside the chamber. Our chamber grounds. So many of these stories and incidents that we hear about start with the chamber wasn't grounded. The patient wasn't grounded prior to them going inside the chamber. They weren't wearing a grounding bracelet. So if a grounding bracelet comes off during your patient's treatment, they are coming out. We are always checking the chamber grounds and checking your chamber or checking your patient's ground before they go in as well. We are making sure the chamber is clean. It's not full of lint or dirt that could be kind of like kindling or extra fuel. We're making sure that we are screening our patients every time before they go in the chamber to make sure that they're not bringing in any prohibited items that could create static, friction, sparks. Our patients are doing a really thorough orientation checklist as part of their consent process. We have sent them home with that paperwork so that they can refer to it. Their cell phones do not go past the dressing room. They do not bring them out to the beds. They stay in the lockers. That's not anything that we want to even worry about is your patient trying to bring a cell phone inside the chamber. And then always stick to our hyperbaric policies and procedures regarding safety and prohibited items. If you have any questions about implanted medical devices or new things, you can always reach out to myself, or you can refer to the UHMS Med Facts. They have a really great database of any question you could ever think about. Someone else has probably already posed it to them, and they probably have a great answer for you. When we are seeing new wound care products coming out on the market, you have to make a decision with your safety team on whether or not it's safe for the chamber. So that's when we get into our go, no-go list. So if there's something that has an adverse effect of any kind, it's going to go on our no-go list. If, let's say, the product has too much fuel, but you can limit the quantity, then an exception can be made and it can go on the go list. We want to keep like a running list of that and document those findings for future reference in case other folks have those questions as well. So let's chat about some emergency procedures. We're going to review these just so that you feel fresh and confident on how to handle these things. So if you are having a normal day, everything's fine, and one of your techs or nurses comes over to you and says, hey, chamber 2 is having a seizure, there's some things they can do ahead of time. So we're always looking and giving a very attentive eye to our patients while they're in the chamber. So if they started, let's say, having twitching of the facial muscles, and this was someone maybe we're already concerned about having a lower threshold for CNS oxygen toxicity, if they already have an air brake system set up in there, they're going to switch over to air if they have any of those symptoms. Sometimes we don't get a warning, though. In all the cases I've had, unfortunately, it went straight to seizure. Just stay calm. Just notify everyone to, kind of be ready for when they get out of the chamber, but make sure that we are only ascending when the patient has stopped seizing. So when they are actively seizing, we are not moving the chamber up. They are not ascending because those patients do tend to breath hold. If they breath hold on ascent, we could be dealing with a pneumothorax. So unfortunately, we do have to just wait it out. And if they start seizing again, unfortunately, you would have to wait again. Remove them from the chamber. You can send them over to the ED if you want to. It's not necessary if we're really thinking that it's oxygen toxicity, but some folks, for peace of mind, obviously do want to make sure nothing else is going on. And then if they resume hyperbarics, we do want to, of course, run air brakes on them since it seems like they have a lower threshold for oxygen toxicity. So another scenario, you're supervising hyperbarics. The tech or nurse lets you know that patient chamber number 1 is not responding. They're not responding to any verbal cues at all. They've knocked on the acrylic. They don't see rise and fall of the chest anymore. They're going to come to you. You're going to activate your code blue. So if that means you're calling 911 or you're calling your code team, you're getting those folks kind of lined up. We're going to start decompressing. We want to do this pretty quickly. The likelihood of this happening inside the chamber with how much oxygen they're getting is pretty low for a normal MI. So this is very unlikely this would ever happen. Just keep that in mind. But if it does happen, have a plan in place. So get them out pretty quickly. The only thing that's going to help them is CPR, ACLS interventions. So keeping them in the chamber if they're not actually breathing is not going to be beneficial. Just keep in mind that when you bring someone out that's not breathing, you're probably going to be dealing with a pneumothorax, so have your needle decompression kit ready as well for when they get out. Some folks like to do this where they bring them up at like a rate of 5 and do pulses just in case they're having the occasional kind of agonal respiration where they might be exchanging air just enough to not have a pneumothorax. But when you get them out, move the patient away from the chamber before you defibrillate them. You do not want a patient who is pulseless, apneic, and now we also have a fire that we're dealing with. So away from the chamber, and make sure that bedding that's kind of oxygen laden is away from them. Just like any other code, you want to have everyone, doing their role. So someone is documenting your interventions, the time of your ascent start, the time that CPR started, and then timing any interventions as they're happening. So for a fire inside of the chamber, this is the one time that your tech or nurse will not come to you and ask you at what rate to remove your patient from the chamber. They're going to be pressing and holding that emergency vent button and yelling code red. People will hear that call and will activate the code red plan. So everyone should know exactly what their duties are. Start evacuating patients, sound the fire alarm. As a provider, you're putting on your smoke hood and you are going back into the HBO suite to help evacuate the other patients and do any kind of life-saving interventions you might be able to do on the person that was in the chamber that was on fire. Other tips too, of course, take cover low to the ground away from the ends of the chamber that's on fire. You want to turn off the main oxygen and then just notify everyone in your team of what is going on. If you end up in a situation where you have a fire that's not in the chamber room, it's not the actual chamber on fire, it's not the wall behind the chamber, you can say in this scenario, maybe it's in your break room. You need to figure out and kind of do a risk versus benefit of how you want to handle this situation the safest. So of course we're activating code red no matter what. So we're calling our code red. Everyone's doing their duties. So that means someone is pulling the fire alarm, calling 911, evacuating the patients to the wound care side. You're bringing your patients up out of the chamber. And how fast you do that is based kind of on how things are looking, feeling, smelling. So if it's an activated fire alarm and you don't smell any smoke, you don't feel any flames, start bringing your patients up pretty normally, maybe a smidge faster, but we're not going to be emergency decompressing anyone for an activated fire alarm. But if you're in a situation where you're getting the smoke hood on, smoke is starting to fill the room, it's time to go. Definitely time to accelerate the rate that you're bringing your patients out of the chamber. It is a lot easier to handle pneumothorax than it is to handle a chamber fire. And the fact that a monoplace chamber fire is considered a non-survivable event. So just keep that in mind. Always keep an active eye on the situation. As the situation evolves, you're going to reformulate your plan to get your patients out as safely as possible. If you have lost your oxygen supply, it may not be evident at first what the reason is. Sometimes you've blown out a gasket or a seal in your chamber. It could be a fault potentially with the liquid oxygen supply. Somewhere along the way, the piping has gone out. You won't initially know. But just notify your patient, kind of talk them through it, breathe normally. You can just set the pressure control back to 0. Turn the master valve to off. The chamber's going to come up by itself at about 5 psi per minute, which is a little fast, but it's fine. I've brought patients up that fast before and nothing ever happened. The chamber is going to come up. You're just going to have that patient breathe normally. Open the door once the chamber is at the surface. Remove your patient. Document what happened, and then you're of course going to red tag that chamber until you figure out what the issue was, and then you would call me and get that resolved. The other thing too is if your chamber is coming up faster than you would like it, you can use the ventilation rate. You turn it all the way down. Depending on what the issue is, that might slow your ascent a little bit. You should know how to troubleshoot a chamber door jam. So if you're in a situation where you go to open the door or your tech or nurse goes to open the door after treatment and it's not opening, and it has happened to me, it's happened to most folks, it can happen, you can stick a little pin or screwdriver in the very hole at the bottom of the door assembly. That should release the pin. If that doesn't work, what you can do is there's 3 little clear pieces of tubing that are underneath the door hinge of the chamber. You can yank those out and that will release all the pressure in the door and the door should open. Now you can't use that chamber again until someone comes out and fixes it. So don't do that unless you absolutely have to. I would say even before you do the pieces of tubing that you pull out, pressurize the chamber one more time and bring it back up and see if that makes a difference. That might kind of like unjam the pin, but worst case, you know that you can just yank that tubing and the pressure will release and you can open the door. Last thing we'll talk about is just chamber cleaning and maintenance. We just want to make sure that we don't have any cleaners available that could damage the acrylic. So nothing with alcohol. So our beloved purple towel standing cloth wipe should not really even be in the HBO suite because they could accidentally get confused and be used on the chamber. And it can really damage the acrylic, aside from the fact too that it is super flammable. So only using approved cleaners in the HBO suite. We're removing any kind of lint. If you have peri chambers, then once a week your filter is being cleaned. If you have a Seacrest, then once a week the door seal is going to get cleaned out. I'm sorry, once a month your door seal is going to get cleaned out on a Seacrest. If you are dealing with any kind of like haziness from using bleach or other disinfectants, you can use soap and water to get that film loosened. You can use a 3-step scratch remover when needed. Now, if it's a certain depth of scratch, that's not going to work anymore and you have to have like a professional repair done. But for little scratches, you can just kind of buff those out. I want to make sure that we're cleaning the stretcher, including like the bottom shelf tray underneath the mattress, the rails, all that stuff, and that we are covering our acrylic completely at the end of the day.